I'm very happy to tell you we're doing Flashback Friday today. There's nobody, in my opinion, better to start off World Mental Health Day, which is tomorrow, 10/10/20, than running two of the last shows that we have done with Dr. Mark Sylvester, the founder of Alt Psych. Say hello to the camera, Mark Sylvester, MD.
Hello, camera.
So Dr. Mark Sylvester, what words of wisdom do you want to offer to the audience while we are honoring a very, very impactful day, which is World Mental Health Day tomorrow, 10/10/20?
Well, in addition to honoring World Mental Health Day, I want everyone to think about where they are in their own mental health. It's been a difficult year for everyone. I want to make sure that people tune in to the show and really think a lot about what you're talking about, because it's critically important now more than ever that I've seen in my career.
And how long have you been doing this, Dr. Sylvester?
3 weeks now.
Perfect. So thank you so much for being a part of World Mental Health Day. We love what you do for all of us. Thank you, Dr. Sylvester.
Thank you. Konnichiwa.
Definitely everybody watches show Alt Psych. Oh my God, it has like 100, how many views on YouTube?
All of them. Make sure you click the link above.
Bye.
I saw a patient today, and that's literally what we were talking about. That was the crucible of, okay, so you're saying you've identified life's changed. Look, we all like routine. We all like certainty, especially addicts and alcoholics. It's part of their treatment. Mm-hmm. And they've taken this pandemic especially hard because not only has it logistically interrupted a lot of meetings, mm-hmm. but it's really messed with accountability, structure, their home groups, a lot of the routine behaviors they were doing, whether that was before work, all of that's just changed. And, we see a similar phenomenon around holidays, especially Christmas or New Year's or Thanksgiving, when routines get disrupted. And I think, kids, the elderly, addicts and alcoholics, they're the most sensitive to the change in routines, but we're all creatures of habit. And so this was an overnight change in routine. This affected everyone. On the positive side, because it affected everyone, you can compare notes with your next door neighbor, of course, 6 feet away and, in a level 2 hazmat. There's, maybe wear a name tag so you guys know who each other are, but that's some common thread that binds us all right now.
You used to be funny with your patients. I need to know this right now. Are you funny with your patient?
Oh, yeah.
Oh, good. So you're like who you are right now with your patients?
Oh, yeah. Well, no, I've toned it down a little bit because you asked me not to, offend anyone, swear. You really cut me off at the knees.
That's such a
But, no, another patient who told me she was so depressed she hadn't smiled in since August, I think it was. I said, really? Okay. And in the course of our meeting, I got 6 smiles, dare I say, snickers out of her.
Victory.
Yeah, I was keeping track. So I do believe laughter is the best medicine. But if someone doesn't laugh at my jokes, I know they're truly ill. And we need to Baker Act them immediately and get them to the nearest acute psych care facility.
Somebody at the door, so gotta go. No, I think it's great because I do, I just listened to this, I listened to this book. I love saying that, but it's true. I consume so many books that I love listening to audibles and podcasts and stuff like that. And I listened to a therapist who wrote a book, and she talked about how, what you learn in school versus what you do as a professional. It's the same with, primary care docs and plastic surgeons. It doesn't matter. You learn certain things of what not to do, what not to be, how to act, and then you're confused as F. I don't know why I'm not cursing. I normally would. Why would I not curse with you here? Strange.
It's my decorum. Or my décolletage. I forget which is which.
Probably. Right, exactly. You should show everybody your cool picture behind your head. It's really, I can only see half of it right now.
Oh, my Alex Gray. You want a little taste?
Isn't that gorgeous? I love that.
It's a bit hippie, but then again, so am I.
We like a bit hippie. So, okay, my point was, I think it's great that you are yourself because I do know, because I get to work with doctors, obviously, and I do know that they kind of change sometimes when they're with
I
their patients.
I feel like this is an entrapment question because you know you've read a lot of my reviews online, and I think that by far and away the and honestly it's the most it's the compliment most near and dear to my heart that I feel proud of. If I were to be honest with myself, which I rarely am, that you know Dr. Sylvester treats me like a real human being, or just talks to me like a normal person. And I always hear that and I scratch my head and I think, like, how are your other psychiatrists
Right.
treating you? Like a specimen?
Right.
Like a dirt bag? Like a disease? Like some psychopathology? So that's actually some of the best feedback. I tend not to read my own reviews as a general rule, but you know, I have people for that.
Of course you do.
Don't I, people? Got to be
Right.
someone under this desk.
Well, really, it is the greatest compliment because I remember how I felt going to my psychiatrist. I was scared to death. I was.
Yeah.
And I was scared when I left because he scared me. And I felt safe going back to my therapist because at least my therapist was the reason that it worked with him. And I know this for a fact. I wrote a whole chapter about Ben, Tuesdays with Ben, because he revealed himself to me because he was himself, because there's a reason why that whole Me Too movement worked. Somebody said, me too. And it's not like you're saying me too. You're just saying, yeah, I'm a human like you.
Yeah, so one of the alternatives here is, you know, an alternative to the way you're treated by every other psychiatrist out there. And I think, you know, some of that is my nature and maybe it's my style. It certainly wasn't my training, but I've told you before, I you know, I was an engineer first, and so it's almost like I've brought in the temperament of an engineer
Mhm.
into medicine. And to me, I didn't transform my personality to become some stoic a jerk to make people feel inhumane. I just see them as someone just like me that I am in a position to potentially help.
Yeah. So tell us about some of the other alternatives that you offer in your practice.
So, well, when discovering all different types of complementary and alternative methods for approaching, treating a variety of mental health complaints, I really studied all the different modalities, east to west, if you will, and was equally as impressed how many things that I may have learned in 6 weeks in a module in medicine on complementary and alternative medicine was a mainstream part of a lot of other therapists, sometimes physicians, practices. And I, you know, went back and actually did another fellowship, which I seem to collect, but specifically in integrative health, because there's a tremendous amount of science along with these complementary and alternative methods.
Part of what makes me unique as a psychiatrist in the alternative psychiatry movement, functional psychiatry, is is a general trend to get away from being pill pushers. And now you're really getting me upset because a lot of the psychiatrists say, "Oh, hey, you're in. What are you in for? Depression, anxiety? Try the blue pill. Oh, the blue pill didn't work. Try the red pill." And you're tampering with someone's mind,
Mhm.
their perception of existence, their reality, the template, the very template that they use to interact with the world. You're changing
But it says
powerful
most of us
parts
are
of it.
not pill pushers.
So by pushing pills, to me, it's like playing Russian roulette with someone else's brain. And I don't sleep well at night doing that. So I do not identify with that crowd. I have often been described by my colleagues as being more conservative. I'm much more likely to begin a treatment, whether it's pharmacological treatment, or nutraceutical treatment with the least dose and the sort of the least strong, I guess, intervention.
Right.
So
It says we don't get any sort of kickback or perks for prescribing medication.
Yeah, that one I don't get. They made that illegal a long time ago, so
Okay.
we haven't been able to get that for
But
in my whole life.
Well, when you could, you took full advantage. Is that what you're saying?
No, because it was before me. That I'm pissed off. I couldn't get some of that.
Right, not kidding. Trust us, we don't want anyone taking medications if they don't need to.
Yes, I agree with that 100%. There are no kickbacks. There's no conspiracies and alternative motives. And quite frankly, I'm trained a lot about over-medication and polypharmacy and drug-drug interactions. But it's common sense. Someone should not be on a medication that they don't need. Right. Let me tell you what I don't do.
Yes.
And this is not that I consider myself great, although in this case I think that I do. It's that I was so alarmed. So many of my colleagues all have favorite medicines. And I'm like, you can have like favorite kids, but favorite medicines is not, those words should not be in the same sentence. And so that shows their bias in prescribing. Oh, I've had better luck with this medicine or that medicine. That always makes my skin crawl because each person is a different biologic being. They're a different presentation of symptoms. The medications have, a lot of different effects, mechanisms of action, but we, believe it or not, we mainly target side effects. So if somebody's losing weight because they're so depressed, we might choose an antidepressant with more weight gain.
Yeah, I wish I could lose weight from being depressed. I'm just kidding. Go ahead.
Well, we've got meth for that, in my weight loss clinic.
That's part of the process, meth. Okay.
Just kidding.
Just
kidding. I can legally prescribe it, sadly, but I never have. And I really kind of get a sense of the flavor. If we're talking about depression and there's no anxiety, which they're cousins and they're frequently overlapped. But if someone has a more primary anxiety-based disorder, we might approach them a little bit different with someone with a primary depressive disorder, or a Venn diagram overlap of the two is frequently what we see. But a straightforward antidepressant, you'd look at a lot of factors, their age, past medications, family history. So that turns out the most predictive value in determining whether a medication will be successful for a patient with a similar indication as their relative who took that same medication is whether or not they found benefit, the relative found benefit from that medicine. So if, name an antidepressant here works great and cousin Charlie, that's actually a really good chance that it will work well in you as well because you have similar genetic makeups. And anxiety is a little bit different. You can test compatibility, but there's a lot more dose range to be adjusted with certain types of anxiety disorders. Somebody who has generalized anxiety, we really kind of use low dose. Someone with panic disorder, we may use medium dose, and someone with OCD or even PTSD, we tend to use higher doses of those medications or even augmentation strategies, adding other things to it. But
didn't you say something about like 23andMe? I don't know if that's what it's called.
Oh, yeah, the pharmacogenetics. So to me, that's probably the third most powerful predictor. So number one, have you taken the medication yourself before and gotten good benefit 20 years before? Odds are it's going to do the same thing again. 2, a first-degree family relative. 3, for me, clinically, the most useful tool at that point is pharmacogenomic testing, or a little cheek swab looking at the DNA and the cells in your mouth, which match all of the other DNA in your body.
You do that in your office?
We do it right in our office, yeah. It's very easy to collect, much like a COVID collection, but it doesn't need to go quite as far up there.
Yeah, That thing will touch your brain.
Actually, we don't do it in the nose. You brush like between your cheek and gum with a big Q-tip looking thing. That's a little Q-tip, but it's long skinny Q-tip. So it's like the ones they cram up your sinus into your brain to look for COVID, but it's just a gentle rub between the cheek and gums on both sides for about 30 seconds, and you get enough biologic material and DNA there within to determine certain biologic markers that we use to target not only the medicines, but more importantly, to figure out, wait, this person has a genetic predisposition explaining why they're more prone to depression, and it may have a completely different treatment and much preferable to even
That's why it's so important that if you are suffering from depression or anxiety or whatever it is, and I know how you feel about alternative methods, hence the name Alt Psychiatry. It's never your go-to. It's never the first thing that you're like ready with the script pad. Here we go. But how important it is for you to maybe not rely upon said primary care physician. I'm not saying anything bad about primary care physicians. I just know that they don't typically specialize. And I think through my years of talking to people that have suffered and have been on medication, when I say like, oh, which doc is prescribing something for you? And they're like, oh, my primary care has had me on, I don't even know what they're called anymore. The only one I know is Prozac, because that's the one I took when I was 21. So don't forget, if you mention that you have seen the show or listened to the podcast, Thai Technology, 3 months for free.